The next lecture that we're going to have is the Greenberg lecture. Roy Greenberg was a visionary in aortic disease and a prolific investigator who held more than 50 patents that were president at the and received the SVS Medal for Innovation in Vascular Surgery during the 2012 Vascular Annual Meeting. In his honor, the SVS established the Roy Greenberg Distinguished Lecture, which is presented to an investigator who, like Roy, has demonstrated an exceptional commitment to the art and science of vascular surgery and leads a dedicated clinical endovascular program with a strong commitment to education and clinical research of minimally invasive treatments of patients with vascular disease. Dr. Greenberg chose the previous speakers for this lectureship, Dr. Stefan Holland and Dr. Gustavo Oderich. And it's my privilege to introduce Roy's choice for this year's speaker, his friend and colleague, Dr. Matt Eagleton. Their friendship began 20 years ago when, as residents at the University of Rochester, they shared an interest in vascular imaging. In the years following at Cleveland Clinic, they worked together to pursue new technologies to improve intraoperative imaging. His selection for this lectureship is fitting because Matt embodies Roy's commitment to discovering innovative treatments to vascular disease and mentoring future investigators in vascular surgery. Dr. Eagleton is Associate Professor in the Departments of Vascular Surgery and Biomedical Engineering and the Walter W. Buckley Endowed Chair at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. Prior to his appointment to Cleveland Clinic, he was Assistant Professor of Surgery at the University of Michigan in Ann Arbor. Dr. Eagleton is the principal investigator on 15 translational and clinical research studies and was awarded the SVS Foundation NHLBI jointly sponsored Mentor Clinical Scientist Development Award, evaluating the causes and treatments of aortic aneurysms and dissections. Currently, Dr. Eagleton's clinical research is focused on studies evaluating the use of branched and fenestrated aortic endografts to treat complex aortic pathology. Please join me in welcoming Dr. Matthew Eagleton. Congratulations. I'll give you an award if you're glad to be in.
Thank you, Dr. Lawrence, and good afternoon. I'm humbled by the opportunity to honor my friend Roy. Roy was a unique individual with many attributes that made him successful. Some of these characteristics were innate. I'll share with you a story his family shared with me about Roy, when as a child he was found discussing with his sister who they should go to get help with their homework. They decided they would go to their mom if they wanted the correct answer given to them quickly, and they'd go to their father if they wanted the derivation of the formula that would ultimately lead them to the solution to find an answer for the problem. Roy seldom went to his mom. He loved problem solving and he applied this to his daily life and his clinical practice and certainly to his research endeavors. Roy was frequently noted to tell the members of his lab to put science behind your idea and not rely solely on trial and error. He applied this thought process to his interest in research in endovascular therapy. Roy was particularly intrigued by the etiology of endovascular device failures and studied this intently. Many of his graft design ideas stemmed from his interest in the hemodynamic displacement forces placed on stent grafts, and how understanding these forces, especially when applied to endograft design, could lead to the development of even complex branched endografts that mitigated these untoward effects. These are some of the original device designs that Roy sketched in applying these evaluations, and over a several-year period of time, ultimately developed the designs which we still incorporate into our clinical practice in Cleveland, in our treatment of iliac artery aneurysms with the use of a variety of hypogastric branched endografts, and in the treatment of more complex aortic disease, such as thoracoabdominal aortic aneurysms requiring the incorporation of visceral and renal stents. We're able to present this morning the clinical outcomes of nearly a decade of experience in applying these designs to treat extensive thoracoabdominal aortic aneurysms. Roy's innovation and persistence has led to our ability to treat the entire aorta in a less invasive fashion, and catapulted Roy into the role of aortic guru. This used to hang on his door for years. Cleveland certainly benefited from his expertise and efforts. We have 3 physician-sponsored investigational device exemption programs that were initiated by Roy as early as 1999. These programs allow us to treat complex aortic disease, spanning from the aortic root to the femoral arteries, include every branch in between. We have had the luxury of treating over 1,700 patients within these programs, including over 260 juxtarenal aortic aneurysms, over 800 thoracoabdominal aortic aneurysms, 10 total arch replacements, and we've been able to incorporate over 250 hypogastric branch grafts among these repairs. One of Roy's other attributes was his willingness to share his knowledge with others. Roy loved to teach and interact with interested pupils, and we have heard from the first Greenberg lecturer, Stefan Howlon, about the benefits of having trained with Roy and how the opportunities he provided have influenced careers across the globe. In addition, we've heard from Gustavo Oderich, who'd been mentored by Roy, about how this knowledge is transferable in skilled hands and can be utilized to develop tremendously successful programs at other sites, much to the chagrin of those of us that work at the center of the universe, the Cleveland Clinic. One of the questions Roy was asked frequently by his mentees was, how do you achieve success? How can I be like you? How can I be innovative? Roy rarely had an answer for them. These are not easy questions to answer, but there's a science of assessing the methodologies of innovation. Innovations requires leadership and a culture that supports innovative efforts. It requires individuals with passion and creative thinking. It requires individuals who are not afraid of taking risks and who are willing to accept failure. And lastly, it requires community. Rarely is innovation achieved by a single individual, but through the support and input of a group of people with a variety of ideas and approaches. Roy and his opportunities at the Cleveland Clinic embodied all of these. The clinic offers a unique environment in which innovation is encouraged, and like-minded individuals are drawn to both the institution and to each other with the mentality of improving upon what we do. The environment was clearly augmented by Roy's drive and thought process.
Roy looks at things and thinks about things in ways the rest of us don't. There's no other person I know of who has that kind of thought process to get things, his mind, into patient usage and have patients really benefit from his innovation.
Roy was a creative thinker. He not only had the ability to think outside the box, he's also able to think inside the box, but probably more importantly, he's able to think about the box. And he successfully recruited other passionate individuals and provided them the opportunity to learn and grow, and to get excited about what the team was working on. None of this happened overnight. Innovation takes time and effort, and then more time, and then even more effort. The path to innovation is a long journey, a peregrination to innovation, and unfortunately in this case it was abridged. Roy had many interests that stemmed from his love of aortic disease. He had multiple patents based around his interest in aortic endografting and endovascular therapy, and he developed other research programs focused on genetics of aortic disease, programs to improve radiation safety for those performing these procedures, and research programs evaluating imaging technologies to help make application of endovascular technology easier. I had the privilege of collaborating with Roy on many of these programs, but it is this latter program in imaging that I actually have the longest history with him. Roy's interest in imaging may be genetic, or at least like aneurysmal disease, familial, as he's influenced by his father, Dr. Don Greenberg, who is a professor of computer graphics and director of the Cornell University program of computer graphics. His interest in vascular disease was sparked by his move to the University of Rochester, an institution that harbored excellence in both the treatment of vascular disease and innovation. He was influenced by the legacy of many individuals there, including Charles Robb, Jim DeWeese, Cy Schwartz, Dick Green, Ken Oriel, and Tim Shooter, to name a few. During his residency, Roy applied his interest in vascular and imaging to carotid artery disease. He was interested in using imaging modalities to risk stratify carotid artery disease based on plaque morphology, but he is underwhelmed by the available imaging at the time to accurately assess this pathology. He wanted to develop an imaging system that could improve our ability to decipher the three-dimensional complexity of the carotid artery plaque. Roy helped to develop an algorithm that could calculate carotid plaque morphology based on angiography. The model integrated multiple angiographic projections, utilizing intensity values to reconstruct the arterial lumen. It was during this time that I first became involved with Roy in his research. We developed initial crude models of arterial stenosis using high-tech equipment such as surgical tubing and PVC piping, and we attached them to perfusion pumps that we borrowed from the university to mimic arterial flow. We then at night snuck into one of the hospitals, and this is Rochester General Hospital, the radiology suites, to perform angiography on our models. We bribed the x-ray techs, usually with a case of beer, to let us in and show us how to use the equipment. With time and money, the models became a bit more sophisticated and the process a lot more legal, and angiographic data was used to display a model depicting the three-dimensional architecture of the carotid plaque, or at least a simple tubular model of it. Cross-sectional and geometric evaluations were made to compare the reconstructed model to the phantom, and error detection was calculated by retrograde projection of the reconstructed three-dimensional model into a two-dimensional plane. Further testing was performed in a more complex model of the carotid artery bifurcation, and we were able to achieve a success with a geometric accuracy approaching 98%. Roy moved on from Rochester and obtained further mentoring in endovascular care from around the globe, but ended up landing in Cleveland at the Cleveland Clinic, where he further developed his interest in endovascular therapy. He had not lost interest, however, in the role of imaging and how it can improve our ability to employ endovascular techniques. He visited Ithaca to, quote, to find nerds interested in this kind of stuff. Here he connected with a graduate student in his father's program interested in vascular-related imaging. Vikash Goel ultimately moved to Cleveland at the completion of his education to join the research team. The research lab developed a mathematical model to assist in the understanding and interpretation of DICOM CT data to aid in endovascular surgery. This was actually the basis of Vikash's graduate thesis, and the model was tested by assessing the relative geometry of the aortic branches. The initial model began with a CT scan and the challenge of isolating the region of interest, also known as segmentation. Rudimentary segmentation software was developed combining native and arterial phase CT scans. Further development capitalized on commercially available segmentation solutions such as that provided by TerraRecon, as while the model was independent of segmentation, it required accurate segmentation data. To generate the mathematically derived imaging, a process of edge detection, distance transformation, gradient computation, scalar derivative, peak detection, spline marching, and ultimate surface fitting were employed. The benefit of this modeling technique are that it can be calculated automatically from properly segmented DICOM CT scans. Each model is concise and can be transferred over networks quickly, and a multi-phase CT scan could have sequential models, and differences between each phase or model could be interpolated readily, and the results were repeated with a great degree of accuracy. The algorithm is patient-specific and automatic, and was developed further to understand the geometry of the arterial morphology. The system encoded the shapes of the aorta and branch vessels in ways that would make sense to a computer, so that a CT image could be transformed into an overall model with the aortic component interrogated separately from the branch vessels, and that each branch vessel could then be interrogated separately from each other. The initial interest in this technology was an application to automated sizing for fenestrated stent grafting. The process begins with a CT scan. The region of interest is identified and its data interpreted and extracted, exporting the information to our system, which automatically calculated a center line for the aorta and its branches, and then fit a surface to the lumen. At this point, the CT data is no longer necessary, and the entire process becomes dependent only on the model. What is being projected is a prototype of the automated sizing model, with the physician selecting the proximal and distal extent of the aorta to be included in the repair, and which branches would be incorporated. The program automatically determines the aortic diameter and appropriately oversizes for the intended graft diameter. Fenestration locations are deciphered depending upon which branches are to be incorporated, and a mechanical drawing is produced from which a device could be manufactured. And this directly correlates with the patient's underlying aortic pathology and aortic morphology. An evaluation of this automatic sizing software was presented at the Vascular Annual Meeting in 2007, and the results published in the Journal of Vascular Surgery in 2008, showing congruency between the automated sizing program and physician-based sizing. There was a change in the zeitgeist in the lab at about this time, however, and with a loss of interest in automated sizing for a variety of reasons. There was more interest in precise graft placement. This became especially apparent with the improvements in perioperative 3D CT scan imaging, but relatively poor two-dimensional intraoperative imaging. The lab was at a fork in the road and refocused their efforts toward improved techniques for device delivery and navigation. Carl West, the head of the endovascular research lab, began to develop systems to aid in the challenges of device delivery, while Vikash continued to focus on imaging for navigation. It was also about this time that DICOM overlay images were being applied to guide fluoroscopic-dependent procedures. Similarly, the mathematical model could easily be used in this fashion. The use of the mathematical model provided several advantages for use in this setting. It could be discretized at any resolution, and the mesh appears smooth even when we magnify in. It could be rendered in wireframe, which made it relatively transparent while also clearly demarcated. And it could be broken into its components, including both the single branch arteries as well as the entire aorta. And we had hoped that we could interactively deform this during procedures to anticipate changes in anatomy. I'll discuss that more in a bit. The problem with overlays were that they did not always accurately display the real-time location of anatomy. That is visualized here, where the anticipated left renal artery image does not correlate with where the renal artery trajectory actually occurred. These errors arise secondary to registration challenges and with problems with anatomic deformation. Registration challenges exist when the CT anatomy localization does not correlate with the anatomy identified on fluoroscopic imaging. In this case, the calcified aorta and the spine are easily registered with the preoperative CT scan, but the soft tissue was ultimately in a very different location, affecting the trajectory of the renal artery. In addition, vessel deformation occurs when stiff systems are advanced through the arterial tree, and this is amplified in patients with tortuous anatomy, as is depicted here. The overlay image of the tortuous iliacs do not accommodate with the advancement of the stiff delivery system, which in real time changes their shape and location, thus making the overlay images relatively useless. Roy died on December 7, 2013, after a long battle with cancer. This ended his part of this and many other journeys. And while intellectually we assured ourselves that his cancer biologically was not likely induced by the repeated exposures to radiation from long hours using fluoroscopy, it certainly induced in many of us a level of concern and paranoia. It certainly influenced our research team and unified us in a goal of developing imaging modalities that could potentially limit the use of radiation. This is the team that rallied to alter the direction of the research performed in our labs, and these include Jim Foster on the far left, Vikash Goel on the center left, Carl West on the center right, and Jeff Yanoff on the far right. We sought to develop a non-fluoroscopic 3D image guidance platform that would enable surgeons to have superior visualization and accuracy with limited use of fluoroscopy and radiation. Certainly on our part, this would require improved imaging software and improved navigation hardware. From an imaging perspective, we needed to overcome vessel deformation. We sought to transform our mathematical model so that we could predict how a vessel will change with manipulation and provide a virtual image that exactly mimics real-time anatomy and provide that in a three-dimensional format that's easy to interpret and understand. With our mathematical model, we could predict vessel deformation. It could be programmed to anticipate deformation and alter discrete points along the visualized arterial model to correlate with real-time anatomic changes. It's based on fixed naturally occurring anatomic arterial points, as well as taking into account wire and device stiffness that must be specified interactively with the program, and it takes into account arterial compliance calculation based on the fixed segments of the arteries, as well as dependent upon calcification scores. This can be applied to an overlay image to demonstrate how the vasculature would respond to manipulation. In this scenario, we can predict how a tortuous iliac system will respond to stiff wire insertion, and accurately predict how the iliacs will straighten or accommodate accordingly, and provide this with a three-dimensional overlay image in real time. Not all devices provide the same degree of stiffness, and we can predict incremental deformation at a variety of degree of device stiffnesses. This is the alteration of a celiac artery with simulation of different wire insertions. If we initially insert just a low stiffness wire, we see minimal deformation of the vessel. As we advance the stiffness of the wire, this is a medium stiffness wire with more deformation of the vessel, more straightening while the wire is advanced. And finally, with advancement of a very stiff wire, we see complete straightening of the artery, and it maintains that location as well as long as the wire is intact. We had made great strides in developing an imaging system that provides sophisticated deformable imaging that correlates with real-time anatomy. We can predict how the specific anatomy changes with device manipulation. What we needed to develop was a way to know where our devices were relative to that anatomy, and then display that within the images we were predicting. And we invested in hardware development with incorporation of a GPS-like system for our endovascular tools. We developed catheter, wire, and sheath systems with embedded sensors. In addition, we developed patient centers to monitor the specific location of the patient. And when combined with our imaging model, we could identify the location of our endovascular tools relative to the patient's anatomy and project that within our mathematically derived image. The detail about the tools, such as catheters, is specific enough that the image will exactly mimic the size and shape of the specific catheters with rotational and cranial caudal accuracy. The images can then be projected on display systems that are easily transportable into operating rooms. To test this, we evolved from crude model developments to ones of increasing sophistication, with significant bench testing to verify accuracy, and intraoperative testing, specifically addressing the need to overcome the electromagnetic distortion put forth by the C-arm, with ultimate success. This represents the virtual image of one of our models rendered after a CT scan that demonstrates our ability to navigate through the model without the use of fluoroscopy or direct visualization of the model and cannulate a renal artery. One of the benefits of this system is that the imaging is three-dimensional and can be manipulated real-time to provide alternate views of the anatomy while we are manipulating through it. 19 years after my initial work with Roy, we sought a clinical application of this technology to assist in branched endograft placement through a Cleveland Clinic program called the Innovative Practice Program. With the images on the left similar to what we currently visualize on fluoroscopy, and the imaging on the right of what the new platform would ultimately reveal. This platform provides improved ability to visualize endovascular manipulations, and in this case, cannulation of the left renal artery. Through the Innovative Practice Program, we ran our imaging system in parallel with standard care fluoroscopy during a branched endograft procedure. The images produced by our model on the right directly correlated with real-time fluoroscopic images that were guiding the procedure on the left. We could accurately detect where our catheters and wire systems were relative to the anatomy, and visualize their changes with device manipulation. This represents the efforts of nearly 2 decades of work of a team of clinicians, researchers, and engineers. It represents many ups and downs, many successes, and many failures, a true peregrination. Our work is not complete. In fact, we're just beginning. We need further refinements of our endovascular tools, including better sensored catheters, wires, and sheaths. And we need further testing of our sensitivity and specificity of the system, comparing to the gold standard of live fluoroscopy. We are also working to incorporate stent graft delivery systems and actual graft sensing and modeling. Based on this modeling, we can determine not just the location of the stent graft within the arterial tree, but we can predict exactly how that specific custom stent graft is aligned within a specific aorta and how that specific stent graft will deploy at a precise location within that specific aorta. Rotation and cranial caudal orientation can be predicted and altered prior to ultimate graft deployment, and this will help to place it with more accuracy and less intra-aortic manipulation.
In 1999, when I came to the Cleveland Clinic, one of my goals was to start a lab where we would develop technologies that would allow us to go into the branches of the arteries. And people laughed at that.
Roy lived innovation, and innovation is what helped launch our specialty in a new age, especially with regards to complex aortic surgery. It has been my privilege to work with him and experience this. We should continue to invest heavily in innovation, which ensures the advancement of not only our specialty, but ultimately provides better patient care. Roy would be thrilled with this program and would cherish the opportunity to hear future speakers describe their triumphs and failures as they face the challenge of improving our approaches to patient care. I look forward to that too. Thank you.
As with us, I know that Roy would be incredibly not only pleased but proud of the progress that you've made since his death. And thank you very much for giving this distinguished lectureship.